Hello, everyone. Welcome to tonight's webinar with Dr. Colin Ryan with Central Ohio Urology Group. So this evening, Dr. Ryan will be speaking about bladder and bowel dysfunction, common symptoms patients experience, and treatment options available. Without further ado, here's Dr. Ryan.
Thank you for joining us tonight for this webinar. So today we're going to talk about bladder and bowel control. We're going to talk a little bit just about the safety information. This is more about how the procedure works and also some precautions. These are more for me than for you. And then we'll talk a little bit about me. So I grew up initially around Cleveland, Ohio. I went to undergraduate for my education at Georgetown University, went to medical school at Ohio State University, and then completed my internship and residency at Stony Brook University Hospital on Long Island before coming back here to Central Ohio. I primarily see a combination of female patients for pelvic organ prolapse, urinary incontinence, overactive bladder, and I also do see male patients as well, primarily for enlarged prostate. But tonight we're going to be talking more about how bowel and bladder symptoms can disrupt your life. So if any of these speak out to you, I constantly have to stop on trips. I miss the best part of the show. I know I need a bathroom nearby. I worry I won't make it. Or if you're one of the people who knows where every bathroom is in all the stores that you visit on a daily basis, this is a good talk for you to be listening to. So these are some misnomers about bladder leaks or incontinence, as it's otherwise known. Your condition's not a normal part of getting older. It's not just part of being a woman. It's not an issue with the prostate, or it's not caused by something you did. And your condition, urinary incontinence, most of the time, impacts your quality of life. It can be your physical quality of life. You can't do the things you want to do because you're worried about leaking, or you know you'll leak if you do X. It can alter your social plans. You may not be able to take that trip. You may not be able to make it 2 rest stops on the highway when you're in your car. There's a psychological risks as well. People who have urinary incontinence often feel guilty or feel embarrassed by their condition. You feel like you're not respected by other people around you, and you have a fear of leaking urine. And then there's definitely an effect on people's sexual life. People who have incontinence during sexual activity avoid sexual contact. They're embarrassed by that as well, even if it's with a partner they've been with for decades. Missing work or having to take absences from meetings at work or not being as productive at work are all complaints that I hear on a daily basis. And then there's also concerns at home. If you have to wash multiple sets of clothes a day because you're having incontinence, or if you're wearing multiple pads or diapers a day, 1, that's expensive, and 2, it's something you have to think about every day and weighs on you. But you're not alone. There are 30 million women in the United States who suffer alone from stress urinary incontinence by itself, not including urge urinary incontinence. It's a condition that affects 1 in 3 women at some point in their lives. So let's try to understand this condition a little bit more. What is stress urinary incontinence? This is a type of urinary leaking that's caused by physical activity. So when you cough, when you sneeze, when you laugh, maybe you pick something heavy up off the floor, you bend over. Sometimes even just walking down and stepping off a curb when walking in the street increases your abdominal pressure, which can push on the bladder and pushes the urine down towards the urethra. The urethra is the small tube that you urinate through. And if you have a strong sphincter muscle, it automatically closes every time you have a sensation that you need to go to the bathroom. But if you have a weaker sphincter muscle, then the urethra remains open when you have one of these physical coughing, laughing, sneezing events, and urine leaks through the weakened urethra. But there are simple treatments for women that can be very helpful for this condition. So what are some of these treatment options? Well, many people have tried Kegel exercises or pelvic floor exercises to help with stress urinary incontinence. And there also is surgical sling therapy, which we'll talk about briefly. But primarily tonight, we're going to talk about urethral bulking therapy. So let's talk initially about stress incontinence management. Some people just need to make some small lifestyle changes to make a big improvement in their incontinence. So maintaining a healthy weight and losing weight if you're overweight, as well as quitting smoking or treating conditions that control any chronic cough, as coughing often causes a lot of this leaking. Pelvic floor exercises are also often recommended to women with incontinence. These can be Kegels, or it can mean a referral to a pelvic floor physical therapist who takes a more holistic look at all the muscles in the pelvis and the hips. There is one surgical therapy that's been around for quite a while. It's called a surgical sling or use of a mesh. Some people have heard of a bladder lift procedure, which is slightly different, but a lot of people who think they've had a bladder lift have actually had a surgical sling implanted. And the goal is to re-support that urethra that's become weak. It has about an 80 to 90% success at long-term follow-up out to 17 years in one study. And it's considered to be the gold standard for many who still surgically manage this condition. One caveat, though, is if you do plan to get pregnant, so for younger women, you may want to wait to have a sling implanted because there is the risk of having tearing of the tissue around the sling or having the sling be disrupted during childbirth. But let's talk about urethral bulking. So urethral bulking is a procedure that doesn't involve incisions. It's a less invasive procedure where a material is injected into the wall of the urethra in order to bulk the wall and prevent leaks. This typically takes place in an outpatient setting and doesn't necessarily require the use of any kind of general anesthetic. And typically you go home the same day. It's also very low risk. There's no implanted mesh. There's no, like I said, there's no incision being made anywhere around the urinary tract. It's an injection that normally takes fewer than 10 minutes. So we'll talk a little bit more about Bulkamid now. Again, this is a minimally invasive, non-mesh alternative to treat stress incontinence. And it's a soft water-based gel that's clinically proven to help improve or even cure stress incontinence in some patients. So how does it work? Let's see if we can get this little video to play here.
Bulkamid can help provide the relief you've been longing for. The short, incision-free procedure typically takes less than 10 minutes. Involves 3 to 4 small injections of soft, water-based gel into the wall of the urethra to help prevent urine from leaking out of the bladder during day-to-day activities. It's safe, quick, and most patients can get back to your normal activities almost immediately.
So I think there's a really great picture within this video where it shows those 4 cushions being placed in the urethra and how much it narrows the tube that you urinate through. So how does it work? When you put those 4 cushions in, you take a tube that is widened and with a muscle that's weakened around it, and you make that internal lumen of that tube, or the internal diameter of that tube, narrower. And what that does is it allows that weakened muscle to still squeeze to close that central tube. This gel has also been shown to incorporate into tissue without causing a reaction of your body's own tissue. So it stays in place, but it's inert. It doesn't react with your body, unlike some previous products that try to do the same thing. But what are the stats with this Bulkamid? What has it been shown to do in clinical trials? So after a Bulkamid injection, 92% of women reported being cured or having significant improvement in their stress incontinence. And as stated before, the procedure is a series of 3 to 4 small injections that normally take 10, even sometimes fewer than 10 minutes, but 10 to 15 minutes in an outpatient setting using simple local anesthetic. When I do this procedure, I normally use a small amount of lidocaine gel inside the urethra that we hold in place with a small swab for about 5 minutes. And that's really it. And Bulkamid has been shown in clinical trials to deliver symptom relief out to 7 years with a single injection. So that's what we're going to talk about tonight about stress incontinence. Stress incontinence is something that a lot of people face. And I think it's important to know that it's not something that you're condemned to if you've had a child or you had a difficult childbirth, if you had a previous surgery inside the urinary tract. It's something that you should come and talk to both your primary care provider and perhaps a urologist about to see if we can help you. This is just some important safety information about some other treatments we're going to talk about here in the near future. So we're going to move on to talk now about a different kind of incontinence. So we just finished talking about stress urinary incontinence, which is when you apply a physical force to the bladder, when you cough, laugh, or sneeze, and have leaking. Now we're going to talk more about a different kind of therapy. So overactive bladder and urge urinary incontinence, which is where you get a sudden urge to urinate and you can't hold the urine until you make it to the bathroom, is a very common condition. It's estimated to affect 15 million people in the United States. And additionally, there's people who have bowel incontinence or fecal incontinence. This is where, again, you may have a sudden urge to have a bowel movement and you can't make it to the bathroom in time. Or occasionally I have patients who don't even know that they're having a small bowel movement until they reach the bathroom and there's stool in their underwear. Only about half of these patients seek care from someone who can help them. And so it's a very under-recognized condition where patients don't know there is something that can be done. And so there's multiple things we're going to talk about, but again, overactive bladder, the sudden urge to urinate and inability to hold or control your urine. Urinary retention is a completely different issue. That's where you have difficulty even beginning to urinate, or you don't empty your bladder completely. And we're going to talk about fecal incontinence, which again is the involuntary loss of stool or having a bowel movement when you don't want to. So how does the normal bladder work? The normal bladder requires you to store urine, and it requires you to empty urine. So when you're storing it, your bladder remains in a relaxed state. It can stretch almost like a balloon. And the muscle around your urethra, or the tube you urinate through, stays closed, even when you're moving around and doing activities. When you want to go to the bathroom, you actually turn off the signal to your bladder telling it to stop. And then your bladder will go. Your bladder contracts or squeezes while the tube that you urinate through, the muscle around it relaxes. So what is overactive bladder? This is a frequent and urgent need to empty your bladder that may or may not result in an unintentional urine loss. So the main symptoms are urinary frequency, urinary urgency, plus or minus urge incontinence, which is an involuntary loss of urine. And often this is accompanied by nocturia, which is waking up at night to use the bathroom, or nighttime urination. Typically, in order to meet the diagnosis of nocturia, it has to happen 2 or more times while you're sleeping. And the urinary frequency can be once every 2 hours. It could be once every 15 minutes. You may not urinate every time you have an urge to go to the bathroom as well. So some people have urgency that's constant, but know that they don't have to go to the bathroom. And so they hold their urine, despite the fact that they know if they hold it too long, they may have a leaking episode. What's fecal incontinence? Uncontrolled loss of stool. So that could be solid, liquid. It could be some mucus in your underwear when you go to use the restroom for other purposes. And you can have sudden urges. You can have urges with leaking. You can have passive incontinence. Passive incontinence is where you don't know you went to the bathroom. And all these things can be extremely disruptive and extremely embarrassing to patients who think that there's very little they can do or that they did something wrong. So just a quick bit on normal bowel function. Normally, as stool moves through the colon into the rectum, stretch receptors in the wall of your colon sense that it's starting to get stretched out. And that sends a signal to your brain saying, hey, we need to use the restroom. So when you need to go use the restroom, go to the toilet, you sit, and you send a signal to your muscles around the rectum in order to relax the muscles that surround the rectum to let the stool move out. Now, for both of these, the overactive bladder, for the urge incontinence, for the fecal incontinence, fecal urgency, there are treatments to help you regain control if you're someone who doesn't have it. And so primarily we'll be talking more about overactive bladder and urinary retention, but I have lots of patients who also come to me and may not share that they have fecal incontinence. This is a massively under-recognized condition because I feel many patients are embarrassed to talk to their physician about it. So the first thing we do when you come is we talk. What are your symptoms? Let's get a baseline diary of your symptoms. I'll give you a diary for you to keep track of. All right, how many times am I using the restroom? How many times did I have a sudden urge where I felt like I couldn't make it? How strong was that urge? How many times did I leak or not make it to the bathroom? And then we may talk about doing some simple tests to make an accurate diagnosis. Sometimes it's as simple as having a urinalysis or a urine dipstick performed in the office to rule out a urinary tract infection. And many patients come to me thinking they're having urinary tract infections, but their doctor keeps telling them, well, no, your culture is negative, but you still have the symptoms of feeling that way, the urgency, the frequency, sometimes some discomfort with bladder filling. These are all things that you come to a specialist to talk about. And then we talk about all kinds of different treatment options. So many patients with overactive bladder come to my office and we'll talk about lifestyle changes you can make. We'll talk about behavioral changes you can make. And we would also talk about, all right, when are you drinking fluids? If you're waking up 4 times at night, are you drinking a lot of water right before bedtime? Well, then maybe we cut back on how much we're drinking before bedtime and move that fluid intake earlier in the day. And that's called first-line therapy. Those are behavioral changes that we make. Occasionally, if you're having a lot of urinary urgency, I may also recommend we try some physical therapy with a pelvic floor physical therapist to see if somebody's hip pain is causing a problem with their bladder or their bowels. But most often, we do start patients simultaneously on a medication to help relax their bladder. And so for overactive bladder, this often includes a medication you take once or twice a day, and we assess your symptoms at a predefined interval of normally 2 to 4 weeks. We'll talk more about advanced therapies in a minute. I'm just going to move through each diagnosis. Another condition I see very often is urinary retention, where patients feel like they don't empty their bladder, or sometimes they don't feel like they are incompletely emptying their bladder, but we check how much urine's left in their bladder after using the restroom, and we find out you're actually holding on to quite a bit of urine after you finish going to the restroom. The problem then is your bladder can only hold so much urine, and so an hour later you feel like you have to go again, and that can be very confusing. This can happen to men or women, just as overactive bladder can happen to men or women. And so behavioral management, recognizing that, all right, we're not emptying the bladder completely, maybe we stay on the toilet a little bit longer and we try to go a second time, or we stand up and know we're going to go back to the restroom in 2 to 5 minutes, is an option for some of these patients. And a lot of the first line therapies or second line therapies, we call initial treatment for fecal incontinence, involves making sure we're eating enough fiber, involves making sure we're not eating foods that we know cause trouble with control of the bowels. Again, pelvic floor physical therapy and pelvic floor exercises can be very important. And then occasionally we try anti-diarrheal medications. However, a lot of patients flip between having constipation and diarrhea along with having fecal incontinence. And so if someone comes having constipation but still having leaking stool, giving someone an anti-diarrheal medication is not always advised. And then we'll talk about some of the advanced therapies. So especially for overactive bladder. Sacral neuromodulation, you will see on all three as a treatment option for these. For overactive bladder, we also have percutaneous tibial nerve stimulation, which we'll briefly touch on, and bladder Botox injections. And for retention, sometimes people need to perform self-catheterization up to 3 to 4 times a day in order to empty their bladder when they can't get all of the urine out. And surgical intervention, we're going to just touch on briefly, but again, it's not something that's routinely performed. And for fecal incontinence, there's very invasive procedures. If you're having a lot of leaking, we can try to bulk the actual muscle that holds the stool in place. Or sometimes patients will find one of the more initial treatments that can work, but often they've met with a gastroenterologist, they've met with a colorectal surgeon or another specialist who may talk to them about these sphincter surgeries, realizing that I don't know if that's right for me. So briefly for overactive bladder, percutaneous tibial nerve stimulation, or PTNS, involves stimulating a nerve that's actually closer to the foot in order to make the bladder relax. And this works in a similar but not direct way to sacral neuromodulation. You stimulate a nerve that's down near your ankle, and this nerve enters into the same area in the spine where the nerve that helps relax and control bladder function enters. And through indirect, what we call crosstalk, whereby stimulating one nerve, a different nerve has a response, we can get the bladder to have reduced urgency, reduced frequency, and often reduced urge incontinence. Now, this is an in-office therapy. It does require a patient to come for a 30-minute session once a week for 12 weeks. And then often we do maintenance therapy, which can be another 30-minute session once every 2 to 4 weeks in perpetuity. And typically after about 6 sessions, we do see quite a big improvement. The main limitation with this therapy tends to be the time it requires out of a patient's life to come to the office every single week for the first 12 weeks. Especially if you're someone who works, this could be pretty disruptive and difficult to do. Botox injections are also a therapy that are used for patients who have failed medication therapy. So what we do is we take a very dilute amount of what's actually botulinum toxin. It's a very powerful neurotoxin that can cause muscle paralysis. So using a very small amount of this, we inject it into the bladder wall during an office procedure. Typically, we use a small scope that has a needle at the end of it, and it feels like a number of pinches inside the bladder that typically take between 5 and 10 minutes to administer. And a lot of patients get quite a big relief from this therapy. And I should mention upfront, PTNS, Botox injections, and sacral neuromodulation all have been proven to have roughly equal efficacy. So the pluses and minuses are more the procedure itself and the long-term durability of that procedure. Now, Botox typically needs to be repeated around every 6 months. We normally quote patients anywhere between 3 and 9 months before you're going to have a return of your urgency, your frequency, and your urgent continence. And some patients continue with Botox for years. Other patients decide after 2 to 3 injections, especially if they have one injection that doesn't work quite as well as the others, that they'd like something with a little bit more predictability. It should also be noted that for Botox injections, while it's a very quick, easy office-based procedure that doesn't require general anesthesia, there is about a 1 to 2% risk of having new urinary retention where the bladder becomes a little bit over-paralyzed and can't empty all the way, which then gives you a higher risk of urinary tract infections and can require a catheter to have to be placed for a short-term period or for a patient to start performing intermittent catheterization on their own. And the third option for overactive bladder is sacral neuromodulation therapy. So what is sacral neuromodulation? That sounds like a big term. Well, basically what we're doing is we're modulating or changing the activity of one of your sacral nerves that helps restore bladder and bowel control. And this nerve that we stimulate is responsible for quite a lot in your pelvis. It helps to relax your bladder. It helps to regulate urgency within the bowels. It helps to limit spasms of the pelvic floor muscles that support the bladder and bowels inside the pelvis. And what happens with this is we have a patient who comes to a procedure suite. We normally do use light sedation for the first procedure, although we can do it under local anesthesia. And we place 2 small leads, which are little electrodes in the back that are about the size of a pencil lead. And this procedure takes about 15 to 20 minutes on average. And you go home with a small battery attached to your back. And we stimulate those nerves continuously. There's nothing that the patient has to do once the device is in place. And so these are some real Axonics therapy patients. Once the device is in place, I kind of call it set it and forget it. It goes in place and we program it to your individual needs to give you the stimulation you need in order to control your bladder and bowels. And this is what Axonics therapy is. This is recommended by the AUA, the American Urologic Association, for overactive bladder therapy to restore normal control of the bladder and bowels. And again, these are patients who may have had an inadequate response to medications or had no response to medications, especially patients who are having significant urge urinary incontinence, overactive bladder, urinary retention, or fecal incontinence. So we talked a little bit about how this works, but it's kind of restoring the normal communication that occurs between your brain, your bladder, and your bowel. You don't want to have a urinary urgency episode, and no one wants to have a fecal or urinary incontinence episode. And so typically patients are always trying to hold, or in the case of urinary retention, you're trying to go. But those signals are not reaching the bladder or bowel with the same signal. It's kind of like you played a game of telephone and you're trying to make it around a group of 20 people with the same message. The message gets skewed as it travels down to the bladder and the bowel. And that can be for a whole host of reasons. Now, if it's determined that Axonics therapy or sacral neuromodulation therapy is right for you, you would do that testing period to see firsthand if it reduces your symptoms. And this is a minimally invasive trial. Again, this could be performed with just local anesthesia in a procedure room. That's the thin wire called a lead that we put near the nerve. It goes right above the buttocks. You go home, you can do your normal activities. I don't restrict almost anything except for going swimming because you have a battery on your back. And then during the trial, your therapy can be adjusted up or down by you. If you're feeling like you're not having enough control, you can increase your stimulation. If you're feeling an uncomfortable sensation from stimulating the nerve, you can turn it down. And you have the power to turn it off at any time if you're feeling uncomfortable. We track your symptoms for anywhere from between 4 and 7 days during the trial period. And if you see a significant improvement, then you would meet back with me or another provider, whoever you saw first, and we would discuss what the next steps are. And if we do decide we're going to implant the final device, there's 2 different options. I call it more of a bladder stimulator, or for some patients who have fecal incontinence, a bowel stimulator. There's a rechargeable option that can last for 20 years or more, and allow you to go anywhere from 6 to even up to 12 months at this point between recharging, depending on how good of a signal we get when we place the lead next to your nerve. And then there's a recharge-free device, which anywhere from 10 to 20 years, we can implant into a patient, and it'll just work for 15 years without you having to do anything. And again, you have a remote. If you ever need to change anything with your therapy, or you're concerned that it's painful or causing other problems, you can turn it off at any time. And we talked just a little bit about each of these. And I think it's important to note also this remote control. There are very few medical devices where you get an up and arrow, a down arrow, and an off or a recycle arrow. And it makes it extremely easy for you to use and to monitor your therapy. If you make changes as well, I'm able to immediately know from my patient's last visit to my patient's next visit, oh, all right, last time we were at this level of stimulation, if you see the green lights on top, we were at 5 green lights. Now we're at 3 green lights. Did we have some kind of painful episode that happened, or did we feel like we weren't able to go? What was going on that caused it to change? It's a very quick and easy way for me to assess how you're doing with your therapy. Most importantly, even though this device contains metallic components, they're all non-magnetic. And so patients can undergo full body MRIs at either 1.5T or 3T, which is a newer, higher powered MRI that's been being used more frequently in the last 5 years. Most importantly, I think this is the biggest, most important slide that we show tonight. 93% of patients have clinically significant improvements in either bowel or bladder incontinence at 2 years after implantation. And the results normally start very early. The results normally start within 2 to 5 days of implanting the device, but you have continued improvement that goes all the way out to 2 years. And again, 2 years after an implant with Axonics Sacral Neuromodulation therapy, over 90% of patients were satisfied with their results. In fact, 94% in one study, with 93% of those patients saying they would undergo the exact same therapy again with the same expected results. And I've performed this procedure in patients anywhere from 19 years of age all the way up to 87 years of age. And I've seen patients who are older experience great benefit from this. So I think it's important that if you're experiencing any of the symptoms we talked about tonight, that you reach out to us, you reach out to me, you reach out to somebody in our practice, and we'd be happy to see you and discuss, all right, I'm somebody who hasn't tried anything. Let's just meet and talk about what can be tried, what can be done to help with overactive bladder, urinary incontinence, fecal incontinence, or urinary retention.
Thank you, Dr. Ryan, for your time tonight. We really appreciate it. And thank you to the audience for attending. We hope this presentation was beneficial to you. And as Dr. Ryan said, if you'd like more information or if you'd like to schedule an appointment, please go ahead and call his office, and you see the number right on the screen there.